Welcome to CR Arthritis. My name is Ellen, and I'm the programs coordinator at Arthritis Consumer Experts. Today, I'm joined by Dr. Lauren King, who is a rheumatologist and a clinician scientist at St. Michael's Hospital and an assistant professor in the Department of Medicine at the University of Toronto. She'll be presenting not once, but twice at the CRA conference this year, once on the topic of asymptomatic knee osteoarthritis and blood glucose control in persons with type 2 diabetes, as well as elucidating the program theory of a successful interdisciplinary team-based model of rheumatology care. Thank you so much for joining us, Dr. King.
No, my pleasure.
So please continue to tell us a little bit more about yourself. And I know how you're involved in rheumatology, but maybe what else you've been up to with some of your latest projects.
Yeah, well, I might just start with, being a rheumatologist means I'm kind of there on the front line of providing clinical care for people living with rheumatic disease. Rheumatologists may see different things in their practice. I consider myself a general rheumatologist, so I have the privilege of seeing people living with a breadth of rheumatic disease. So I think that's really neat about my practice. And you already mentioned I practice in an academic, like a tertiary care hospital in Toronto, so St. Michael's Hospital. But what you're alluding to, the research, is another hat that I get to wear, right? I'm an arthritis researcher. I'm PhD trained in clinical epidemiology. And a big part of my research focus is improving care and outcomes for people living with osteoarthritis. So that's the most common form of arthritis. At least 4 million Canadians are affected, probably more because it's underdiagnosed. So I feel, very charged to be part of this research world.
Absolutely. And as we know, more and more individuals are being diagnosed with every type of arthritis. So I really do think that the role of rheumatologist will only continue to grow. So thank you for, everything that you do and everything that you continue to do, both in practice and in research. I'm very excited to talk to you about this podium presentation. I'm actually working on my practicum right now. I'm in the knee and hip short stay, so surgical short stay at UBC Hospital. So I get to see a lot of these patients actually. And diabetes is a very something I commonly see in individuals' charts. Could you tell us a little bit about some of the key takeaways from your presentation?
So that's interesting that you're there seeing people with, probably advanced symptomatic disease and the impact that it's had on their life. And that you probably see that, it doesn't occur in isolation, right? More and more, it's multimorbidity. That's the norm, people living with 2 or more chronic conditions. And while osteoarthritis, there's been a lot of misconceptions about it, societal misconceptions. Oh, it's just aches or pains. We're increasingly understanding the impact that it has in people living with other chronic conditions, particularly, when there's these conditions that commonly overlap, like diabetes, with osteoarthritis, and how it does impact the management and outcomes of these other chronic conditions. And so really underscoring that OA is a serious disease. So in this study, I guess I should give you some background to what prompted it. So there's been prior work using administrative health data that have shown that OA-related disability in people with type 2 diabetes increases the risk of diabetes-specific complications and cardiovascular events. And so the study that the podium presentation at CRA is really to get understanding this a little bit further and trying to understand the mechanisms. So we conducted a cross-sectional study of people living with type 2 diabetes, and we recruited these participants from diabetes clinics at 3 hospitals in Toronto. We looked at the association between having symptomatic knee osteoarthritis. So everyone had diabetes, but if you looking at the association between symptomatic knee osteoarthritis and being at target blood glucose control. And so we found that, I guess 29%, about 30% of people with diabetes had a diagnosis of, or had symptomatic OA, as we defined it using clinical criteria. So we're not unexpected at all. And if you had symptomatic OA, you were less likely to be at your diabetes blood glucose target, which we defined as a hemoglobin A1C of 7% or less, which is kind of in line with what Diabetes Canada recommends for everyone for most individuals with diabetes. And if we found that, if you had NEOA and you had a minimum threshold of average pain severity, so you said over the last week, my pain is 20 out of 100 on a 0 to 100 numeric rating scale, then this association was even stronger. And it was still there when we adjusted for things that could explain the relationship, like older age or like higher BMI. And so linking back to the prior health administrative data work, this suggests that symptomatic NEOA increases the risk for diabetes complications through impact on blood sugar control, and that the symptom severity of OA is likely important. So, so we're already kind of thinking about, what do we need to do next? And
Yes.
as you always do, right? You finish one study and on to the next. We really need to understand how OA can be better identified and treated in people living with complex chronic disease, like diabetes, to improve overall population health.
So I can see that you have your implementation science hat on. Next step, like you said, I'm also, like I'm part of me is thinking, I'm not surprised about the association.
Mhm.
The other part of me is thinking, but then again, this is something that we don't talk about, right? That hasn't like in for patients, they don't think about because we have separate labels for two different conditions,
Mhm.
but versus thinking about our conditions together more holistically and trying to address them more holistically. So I think again, this work is so important because it's so common. I just want to underscore that for everyone that it is both conditions are very common, both of them are very common together.
So I'm going to go back and tell you my favorite quote from a qualitative study I did as part of my PhD work several years ago. And so I was interviewing people living with type 2 diabetes and osteoarthritis. And there was a participant who said, there's like the diabetes guidelines, there's the OA recommendations, but never the twain shall meet, which was the quote, which I thought was great, right? Because we are so subspecialized, and it's like soon we're going to have like a hand doctor and a foot doctor. Well, I think we already do, but we're just so siloed. But the person is a whole person, right? And we need integrated care to optimize, the best possible outcome for these individuals.
Absolutely. So lots of work for implementation scientists.
Yeah.
And with that, I'd love to ask you about your poster presentation on like exactly as you just mentioned, interdisciplinary team-based model of rheumatology care. Can we start by what is interdisciplinary team-based care for
Mhm.
our audience?
Yeah. So maybe I'll take a step back and say, I think my presentations, I'm only like thinking about it right now, but my presentations reflect who I am as a scientist, right? I have an epidemiologic study and I have an implementation study that we're presenting. So interdisciplinary team-based models of rheumatology care. So it's really with a rheumatologist and an interdisciplinary health professional working collaboratively to deliver care across the spectrum of care too. So this is beyond someone just helping out with one aspect, but an interdisciplinary health professional. It's typically an allied health professional, nurse, PT, OT, pharmacist, who takes on added like an enhanced role beyond their typical scope of care to really team up with a rheumatologist to deliver timely care, to deliver comprehensive care to optimize management and outcomes.
Absolutely. And again, could you share some of the key findings from this study? And what can healthcare providers and people living with arthritis do to make sure this team-based care approach is successful?
Yeah, so I'm one of the scientific leads on this overarching program of research aimed at understanding how can we widely implement and sustain team-based models of rheumatology care, right? Because we have, just as you said earlier, there's increasing numbers of people living with rheumatic disease. The diseases and the treatments in particular are becoming more complex, and we have a pretty stagnant workforce supply. And so to provide timely care, to provide the quality, the comprehensive, the personalized or individualized care that people need, we need novel we need innovative approaches, and this team-based model is what we're proposing. But what are we going to need to what do we need to implement it? And so as part of this program of research where we want to understand team-based models better, we want to have the evidence to support outcomes, the health economics, but we also need to be able to really define what is an optimally functioning team-based model. What are the key ingredients that need to form an optimal team in rheumatology so that this can be spread and scaled and sustained. So as one piece of this overarching research program, so the study that we did was looking at one successful example of team-based rheumatology care in Ontario. And so this is the Center of Arthritis Excellence in Newmarket. And we wanted to understand, or really distill down, what are those key ingredients of team-based care? How do they work? How do they interact to achieve their effects? And so in implementation science, it's called understanding program theory underlying the model. And part of the work then was to simplify it and visually represent it in a logic model. So so that was that's understanding, one model of care. And so it was really helpful to get at the components and the implementation strategies and the mechanisms of action and achieving their effects. But now, this is spawned further work. We need to understand, well, does this make sense in different contexts? We need the opinions we need the input from people working in team-based models at other sites too, to be able to come up with really a master logic model for team-based models of rheumatology care, focusing in Ontario, just more that right now because of healthcare administrated at the provincial level.
Incredible.
Yeah, so yeah, it's a monster project and it's ambitious, but we see it as having a huge potential for impact, and so we're all very excited.
I always ask myself, there's, from someone who's a physiotherapy student, you meet physiotherapists. Some of them are really great, and some of them are magical. Like you don't know what the secret ingredient is. Like that, how are they just able to get people moving? What about their personality? How many times does they see the patient? There's so many variables that we don't always consider that make someone so effective and so good at their job. And sometimes it's maybe unconventional, right? Maybe it's just something about their personality, something about how they speak, how they're able to invoke motivation in a person. But if we want to take those
Replicate
results,
it, yeah.
yeah, replicate it for
You need
everyone.
to be able to pin it down. And so it's kind of like, so we did interviews with patients receiving care. We did interviews with the health professionals there. We went and did observations at the site. We went and looked at all these documents and we triangulated all of this data. And when we got to some core implementation strategies, it's the kind of thing where you say, okay, that makes sense. But you might have not have come up with it de novo at being such a critical strategy. So for instance, the IHPs, interdisciplinary health professionals, really underscore the importance of mentorship. Rheumatology is, if you come through, let's say, PT, rheumatology is still a different world. And if you're practicing, if you're doing assessments, you have medical directives to get some tests done. This is still a different world. And so the importance of mentorship came out, informal and formal, as just such a key strategy to plan for success in this model. You can't just take a PT and say, okay, here's rheumatology. Why would we ever expect, that to be successful, right? That mentorship is so critical.
Absolutely. Well, thank you, Dr. King. That sounds like you said, it's a monster of a project, and I'm very excited to hear more. And maybe in future we'll get to interview you once you've learned more and you've had some results to share with us. I know this year's theme for the CRA is, I'll use my spokesman voice, Ascending to New Heights, Peaks of Innovation in Rheumatology, and it celebrates the latest advancements and breakthroughs, like your research. In your opinion, what are some of the keys for success in putting these advancements into practice? And I know you've already touched on this, especially with the larger projects that you've done. Like, how do we really get these things to stick in the current healthcare system.
Yeah, I like the spokesman voice or spokeswoman voice. And I like the theme for this year's meeting, right? Ascending
Right.
to new heights, peaks of innovation. It's out in the Rockies. I just love it. But yeah, so taking a moment to reflect. I don't know, I kind of want to take a step back and say, you're asking about, what are um, the keys for success for being able to put advancements into practice. But even getting to those advancements is a critical step. And so I think I would say probably perseverance, because science, science takes a lot of perseverance, as you probably know too, in the work that you're doing. So I know it's kind of an unsexy answer, but you can have a great idea, you can have a great research team, but your innovative and important research might not get funded. You might not get to be able to do it right away. So you need upstream, right? You need to have that perseverance, that creativity to be able to get to the point where you have the innovations to put into practice. So maybe that's my first kind of the first thing that comes to mind. But the second is like we have to be charged as a field to take those innovations as they come and not have this huge delay before they're incorporated into practice. And so that's really, with implementation science is a pretty new field to try to figure this out. But I think we need more implementation work to take these great ideas and make sure they're translated into routine clinical care.
Absolutely. We can continue to do better as scientists, and we must continue to do better as scientists. I think there's lots of work out there, and I am very grateful that like rheumatology is so interesting. The rheumatology patients are truly like wonderful. I cannot wait to get into the field and do what I can once I'm all wrapped up school.
Mm-hmm. Yeah, it
Um,
is. And so with rheumatology, right, we see people over a long period of time, right? This isn't like we're not emergency physicians where we treat an acute illness and that's it. We have the privilege of seeing people over a long period of time and through the ups and downs. And I think that's what also makes it really special to be a rheumatologist and or to work as a rheumatology health professional.
Absolutely. And with that, Dr. King, thank you so much for your time. Thank you for sharing your insights with us. And we thank the audience for tuning in. Make sure to check out the other episodes of CR Arthritis. And with that, hope everyone has a lovely day. Goodbye for now.